Today on Cancer Buzz, Oncology Pharmacy, and how new cancer treatments and the shift to value-based healthcare are changing the role of pharmacy in cancer care.
This work requires process owners and it requires content experts. Having a variety of different people with various training touch this type of work intermittently is not necessarily going to be the most efficient or most effective. And so I'd say the takeaways based on the complexity of the work, not only because it's oncology patients and their treatments are complex, but also because of the payer landscape, it's having process owners, having those content experts. I think that the smaller institutions could take away that accessing and understanding your denial data and really understanding where processes broke down, whether it's small scale for a smaller site or large scale for an academic institution, looking to your denial data to help drive front-end change is vitally important.
That was Dr. Suzanne Francart, Assistant Director of Pharmacy at the University of North Carolina Hospitals. She'll be back later in the show to discuss how her department took on the entire process of pre-certification and denials, and now processes more than 10,000 pre-authorizations a year, overturning more than 60% of denials. Welcome to Cancer Buzz. I'm your host, Summer Johnson. Cancer treatments continue to evolve at an accelerating pace, and that's very good news. However, new therapies and treatment regimens require new workflows and add new roles to certain disciplines in oncology. Today, we're focusing on oncology pharmacy. As our understanding grows of the biology of cancer, treatments are advancing rapidly. At the same time, our healthcare system is going through unprecedented change. And in today's oncology ecosystem, so is oncology pharmacy. Changes affecting oncology pharmacy include increasingly complex treatment regimens, including targeted therapies and single and combination immunotherapies, a rise in the number of oral anti-cancer drugs, regulatory demands, specialty pharmacy, inventory management, and the arrival of biosimilars. On top of that, the rising cost of treatment puts a unique strain on the oncology pharmacist in particular. Because of that, pharmacy staff can become financial advocates, handling pre-authorizations and denials and making sure patients get the treatments they need, often with the help of one or more patient assistance programs. Dr. Ali McBride is the clinical coordinator of Hematology and Oncology at the University of Arizona Cancer Center, and he is also the president of ACCC. He spoke with us about the challenges facing oncology pharmacy in 2019.
I think probably the biggest thing or the largest hurdle right now that's facing pharmacy for both those who actually are working in the field of pharmacy or who have pharmacists is the fact that we have a lot of high-cost drug therapies currently in the market. The newer therapies that are coming out actually have a large price tag to it, but also for those patients who are paying part of that copay or even cash based on the fact that they don't have insurance, they are liable for a very large cost. And in dealing with this, we have to address that from a very large standpoint in terms of our personnel. And what we're seeing is the evolution of two workflows. The first is an IV workflow. Again, this is where we're actually having our patients be evaluated for a diagnosis, either get a labeled or off-label treatment. And from that, what we find is we have to make sure the patient actually has the ability to get the drug, which includes working with your patient finance team, checking for paperwork, looking at foundation assistance in these cases, and then putting that patient into play. And most of the time, if we're looking at newer therapies or novel therapies, which are in the labeled or off-label space, we can address that with clinical trial data, specifically in the actual off-label area as well, in which we're seeing a larger area or enterprise come into the IO or IO combination-based therapies. When it comes to the oral is actually a very large and dynamic workflow process. In fact, it probably doubles or quadruples the amount of time that we look at this, and I'll kind of extenuate some of these circumstances as well. If we have a patient, the patient's coming in for a newer therapy, we can say an NTRK inhibitor, an FGFR inhibitor, the patient will actually be diagnosed. We'll have to check the next generation report, whether we're using a CARIS, a Foundation 1. We pull what information is. We detail information out with diagnosis. And then from there, we have a number of team members. We have our specialty pharmacy team working on it. We have our pharmacy technician team working with our patient assistants. We have a nurse navigator working on from education. We have a clinical pharmacist working on from adherence, monitoring, managing, and also mitigating all of the paperwork involved. In fact, even doing the med recs, drug interaction checking, and even the correct dose. And as you see these two lines, separate lines of treatment from the actual IV standpoint and the oral standpoint, and there can be some definitely crosstalk between them because we do have combinations. We can see the large amount of work being done to just address patient care. In many cases, we have had patients with a mail order pharmacy, for example, have the wrong diagnosis or indication of a drug strength being provided, so we've been able to catch that with our team, luckily. Other cases, we have actually had issues addressing copay assistance. We've also even had patients who are getting off-label therapy, which is a whole other process of a denial and appeal situation, in which patients are getting free drug from the manufacturer and should have stopped. So we are actually also detailing out drug waste. A very large amount of the work that we're doing is really reducing drug waste for the patient and also the health system. So really kind of looking at it from a different aspect there as well for the world. So we have a large variety of implications when it comes to these two workflows. And thus, we are really trying to inscribe or delineate a better workflow for this model of care. And that's just one of the areas that we're looking at right now. I think the oral oncolytics in itself, not even discussing what we're facing right now, are becoming a much larger part of our current venue or vernacular of treatment regimens. Sometimes we're doing doublet, triplet, quadruplets of therapy, which are IV and oral. And there's a large lack of education or even workflow processes being developed. In fact, many sites don't have a definitive workflow process with their orals. So that community can go to mail order. There may be lack of checks in regards to these processes. So a lot of workflow development needs to be addressed right now.
So you talked a little bit about patient assistance work. Let's talk about the evolving role of the oncology pharmacist within the cancer care team. They're more patient-facing than ever before, right? They're starting to serve as a financial counselor.
In some cases, absolutely. We are seeing that the pharmacists play a much larger role than they did maybe 5, 10, 15 years ago. And during counseling with the patient, working with other healthcare team members, because again, this is not a team of one in terms of just pharmacy, this is a whole healthcare team in the cancer center. And that interdisciplinary team each has a role. And when talking to patients, we're addressing what the workflow may be, the current areas or venues to get that drug to the patient. And when it comes to off-label discussions, to a much larger extent and also a much larger venue for these overall pieces. And we actually have to go in, discuss with the patient, with maybe another team member, about what the process will be. For an oral oncolytic, for example, we may be actually working with the patient, getting them signed up for the oral chemo. That chemotherapy order is checked with the patient. They do a med rec. We actually have a med rec workflow where all of those patients are checked before they start their oral chemo. And from that standpoint, we actually then can make sure the actual dose is correct. So working with the patient one-on-one, even after the time they go home from counseling, we're doing those double checks. And then once we actually get that right dose, we're making sure the patient's actually being signed up for either the manufacturer patient assistance or a foundation patient assistance based on the type of actual insurance they have. After that fact, we try to actually adjudicate the oral chemotherapy order, and depending on where the insurance tells them to actually pick up their medication or go through for a transfer, we actually work with them on that as well, and then also apply any patient assistance to get that patient started. Now, what makes this even more important is the fact that patients who have a higher copay consistently have lower adherence rates. So the work put in up front at the time that person is diagnosed will clearly help them out later if we can get a lower actual copay for them through patient assistance and foundation assistance as well. So these all go hand in hand because when we're talking about the patient, working with the patient assistance program, it really helps delineate how that patient will actually be maintained on treatment and thus improve outcomes for their diagnosis as well.
I think it's an understatement to say that there's a lot more new information now, right, in cancer care that's flying in so fast. So the oncology pharmacist needs to be educated about these new therapies and how they affect the patient and existing conditions. And that education need is really higher than ever before. So how can pharmacists stay up to date in terms of the evolving information? Where can they turn to?
And that's a great question. And we've seen the evolution of pharmacy grow. ACCC has really done a great job of discussing the practice of pharmacy. And one of the areas which we have seen a large growth over the last few years has been the ACCC Open. And ACCC has the Oncology Pharmacy Education Network, or the Open. And we actually detail out a lot of information in regards to pharmacy management practice in the oncology setting, addressing drug waste, implementing oral chemotherapy workflows and addressing oral chemotherapy implementation as well. Also kind of keeping up to date with USP 797, 800, just to name a few. We have also seen ACCC provide great guidance on the reimbursement and advocacy efforts, which are kind of setting up our workflows for pharmacy in the near future and also the current state of pharmacy as well. So addressing, for example, alternative payment models, looking at different models of reimbursement, addressing oral chemotherapy pieces for implementation based on in-office dispensing versus that of specialty pharmacy. These are just key important pieces.
Our next guest, Dr. Suzanne Francart, has some great takeaways for pharmacy departments of any size. She shares how the pharmacy at UNC hospitals operates efficiently for the patient and the hospital by taking responsibility for pre-authorizations and establishing a closed-loop, pharmacy-managed, proactive pre-certification process.
What at least I have really seen is that the traditional role of the oncology pharmacist in sort of facilitating getting drug to the patient, it's just gone away. And so our oncology trained pharmacists are very well rounded in both helping be at the forefront of deciding what's going to be used to treat the patients, helping facilitate their access to those drugs, understanding the payer landscape or knowing the right people to work with to navigate what's going to be best both clinically, but what also is going to be best financially for these patients and working alongside the physician group in doing this. I think with the increase in drug costs, the increase in the oncology drug pipeline, the complexities of therapies, and then the added layers of the complexities of payer access to care, barriers or obstacles, however you want, but basically those cost containment strategies have introduced numerous steps where the pharmacist can be involved. They can be involved in both what's best clinically in the decision making, what's best operationally to actually facilitate getting the patient their drug and knowing what they're getting and understanding. And then really where our project came in and what we've really started to focus on is where can pharmacy with oncology background and training and collaboration be best suited to help drive reimbursement on behalf of the institutions and focusing on that piece as well. Understanding the clinical decision making, the operational components of getting patients their drug, right patient, right time, and then ensuring that all services are reimbursed appropriately.
What was happening in your pharmacy revenue cycle before the proactive approval process?
Prior to 2014, really there wasn't a single owner for pre-certification for our outpatient infusion centers. And then around that time, our department began to receive questions from non-pharmacy financial leadership about high-dollar drug denials. It was similar around that time. Our clinicians were getting questions from patients about, I didn't know it was going to be this much. Why wasn't this covered? They're receiving communication direct from their insurance companies. And so the combination of questions coming to pharmacy from our financial leadership outside of pharmacy, as well as those patient-directed questions, prompted us to do a real deep dive into our own data to understand better what was happening with our medical benefit billed drugs, these outpatient infusion drugs. And through that investigation, and with significant support holistically from inside and outside the department, our pharmacy department proposed that we own the process, that we go ahead and take ownership of both the pre-certification process, because already we were heavily integrated into the clinical decision-making and handling the operations of getting patients their drug. And so it was that ownership change with support from our senior hospital and physician leadership that is where we were able to implement our mandatory medical benefit pre-certification in the outpatient setting. And that was really the first step of our process back around 2014. And then everything from that has sort of built upon that foundation.
Can you walk us through those steps, the initial steps in 2014 through when the pharmacy department took complete ownership in 2017?
In 2014, really, we already had a team worked on drug access, prior authorization, assistance, manufacturer assistance program enrollment for patients using our retail pharmacy and our specialty pharmacy. And so there was a natural add-on to this group within our med assistance program to take on the pieces now for our outpatient infusions billing on the medical benefit. And so really it was this group combined with universal leadership support to implement policy changes where drugs now the orders had to be entered 7 days prior to starting therapy, and drugs would not be dispensed from our pharmacy until authorization was in place. And so that was a significant culture change institutionally, is we're going to build a policy that says this is required, and we're going to enforce it with support from our operational pharmacies and our pre-certification team. That was the primary change in the beginning. We added on to the team the Med Assistance Program team, which was a group that was primarily advanced pharmacy technicians doing that pharmacy benefit work. And they began growing through an electronic process within our electronic health record referral-based program to identify newly started patients to complete the pre-certification, which includes benefits investigation, prior authorization, assistance enrollment if they were an uninsured or their prior auth was denied. And so we worked through first building that streamlined process within the pre-certification team, and all of this is communicated back in the electronic health record to the provider and transparent to everybody into the chart, as well as to the pharmacy operational team that would be waiting on this information to decide about dispensing. And it was also through this workflow we were easily able to see which patients could we really begin supporting with manufacturer-supported patient assistance programs, those free programs. And as a state institution, we have a large number of uninsured patients or underinsured patients. And so this infrastructure for pre-certification led us to be able to build the platform for identifying those patients, enrolling them into the manufacturer programs, and then sort of facilitating the feedback to get both billing groups and our pharmacies that those patients were taken care of so they could then get their drug at no cost and not have to worry about that piece. And so that's vital for the patient experience, but it's also important to the institution as we're going to take care of these patients no matter what. And if there's an opportunity to mitigate the drug expense, that's the fiscally responsible thing to do for UNC.
How about the process for denial management? Walk us through that.
Building upon pre-certification and the manufacturer-supported enrollment, we in 2016 identified through a multidisciplinary quality improvement project looking at infusion denials, really looking closer at the data, that this is something that we would also like to own. It was sort of the missing piece of our pre-certification model, that we were doing the work proactively on the front end, but not fully able to see what was happening post-claim, post-bill, as far as denials. And so in 2017 is when pharmacy leadership moved, and we worked very closely with hospital billing to justify and move denials management for outpatient infusion into the pharmacy department. Just believing that a pharmacist-led denials team has the clinical expertise to craft the strong clinical appeal, that there's a direct understanding of what's happening operationally in pharmacy, as well as the ability to piece together the clinical picture for that patient about when you're crafting that justify appeal, especially if some denial is coming in saying this is not medically necessary or this is experimental. And so that was really the next step in our growth, was to transition into building a closed loop denials management program within the pharmacy department. Definitely continuing to work with patient financial services and coding and HIM and those groups, but the primary ownership living within pharmacy. And through that, really what we were able to do, and what I consider sort of the best practice in all of this, is the closed loop continuous feedback that's able to come. And so when you're actually seeing your denials data, when you're actually seeing the response, this is what's able to help us drive front-end change. And so make adjustments into the pre-certification program? Are there certain payer trends? Are there certain common mistakes being made by the pre-certification team? What is the denial data showing us that we can use to improve our pre-certification process, as well as what is this information showing us that we can use to educate our operational pharmacy areas and those clinics and those providers? If you see a trend in somebody doing same-day treatments, okay, maybe that's something that we can see in denial data and provide really objective information about what's the financial impact of doing that. And so it's that continuous quality improvement program that is really the best practice and broadly applicable by having all of the pieces of operational pharmacy, pre-certification, denials management, and an awareness of the clinical decision-making for these patients.
That's a major cultural change.
Yes.
What are the benefits to the institution, and did you need to get any buy-in from leadership?
With any change, we needed to get buy-in from leadership, but I think that we have a great partnership with the leadership within our institution in these various areas, and everyone had identified when it was the pre-certification discussion, okay, this is a process. Who's going to step up and want to own it? And so I think the big cultural change was not shifting it to pharmacy to own it and taking away something from another group. It was more of the cultural change of we're going to enforce a policy on this. And so we're going to have to provide the data, provide the information, and justify why we're going to change practice of allowing same-day treatments or next-day treatments. What is the implication both to the institution and to the patient? What is the financial risk here of doing that versus what's best for the patient clinically? And how do you balance both of those things? And so for the pre-certification, there really was not pushback that pharmacy was going to take ownership of it. There was certainly accountability. We were going to have to be accountable to doing it and doing it well and doing it timely and abiding by our own policies. For the denials management, hospital billing was very collaborative with us. Again, it was something where another group was owning it, but we were willing to take on that work. And it was more of a, okay, we'll work with you to build the process and give it to you. However, we're going to also hold you accountable to do it well and to make sure that the process works and it's financially responsible. And so we've had continuous, from the beginning, routine meetings with patient financial services leaders to look in work queues, to look at the data. Is it working? Is the process working? And to improve upon it. And really after that those early on successes and wins and a lot of credibility honestly goes to the team members that I have that were doing the work and partnering. Now it's something that they value and they appreciate, and there's no discussion of should this live within pharmacy or come out to another group. And so I think it's just that those baby steps of building the relationships, being willing to take it on, living up to the accountability expectations from our sort of external customers, and then continuously working on trying to collaborate.
Have your patients felt the change too?
The patients probably feel an indirect change. I think the patients that feel the change feel the biggest impact when we're able to get them free drug. And there's a direct correlation between we were able to enroll you into free drug programs and you have no drug charge on your bill. You don't have to worry about that element of your cost of care. And so there is a direct correlation there. And fiscal year 19, we did over $10 million of drug. That's acquisition cost of drug. That's not even charges. There's a huge impact. That was for over 700 patients across our service lines in infusion. And so I think there is a direct impact to the patients that they feel and that they didn't ever see those charges. They don't have to worry about that expense. I think one of the other areas that's maybe not necessarily noticed, but if it wasn't there, the patients would definitely feel was if we weren't doing the pre-certification and doing it well and getting it correct, they would be getting denials from their insurance company. And then there would be the question of, is this patient responsibility? Is this institution responsibility? Can they continue treatment? And so having a clean process on the front end almost removes that barrier that they may not even know is there, but certainly we're aware of and working on their behalf. I think the other piece that's really directly impactful to patients is if we are able to do this quickly, if we're able to do it efficiently and do it correctly the first time, this should have minimal impact at all to when patients can start their treatment. And so I think that's always been a big concern for folks is that the pre-certification process can significantly delay time to start treatment. And if not done efficiently, and effectively on the first time, those are very stressful moments for patients if they're ready to start their treatment. And so for us, I think that's been a focus that they're scheduled for their infusion visit and maybe kind of duck on the water. They don't see the legs spinning under the surface, but that's sort of what we're doing on their behalf so that when they come for that infusion appointment, all they know is they're being taken care of and they're getting what they need.
Let's talk about that timeline. What does that look like in the cycle from the time the treatment is ordered to administered?
Our policy is that we ask for patients not to be scheduled within 7 days of when the orders are written. So if the patient is seen in clinic and a decision is made on what to start, the minute that orders are written, it automatically drops a referral to our pre-certification team. And so we complete over 11,000 pre-certifications a year, and the majority of them are within 72 hours of when the drug is ordered. And so we try to keep an operational expectation that within 72 hours of receiving that referral, we will be able to get it approved. Sometimes payers drive that timeline, and there's pieces we can control and pieces that we can't. So we will certainly expedite cases when possible. But we ask for 7 days basically as a way to allow time for this process to happen. I think anything significantly shorter than that would not support the ebbs and flows of busy times of the year, like the first of the year when everybody changes insurances and everybody has new insurance and things need to be reauthorized. And so that's the decision. I think that the policy is 7 days, and for the majority of patients, that's a reasonable timeline. That does give the team time to complete the prior authorization, submit medical records, or even get clarifying information from the providers, whoever is prescribing the therapy, if pieces of information are missing or that are needed, and have sort of our appropriate response time there before the team submits the prior authorization request.
You talked about your continuous quality improvement program. What sort of data do you track?
It started through our denials management program. And so instead of just looking at what are the denials coming in, what is the dollar amount associated with the denials coming in, the focus has been why are they coming in instead of what is it. And so that why, that root cause analysis is what's able to drive the front end change. And so from our perspective, the data that we track and that we're able to provide back to drive change is twofold. It's certainly financial, but it's also what is the root cause of why that denial occurred. It's data at the level of what is the drug, where was it prescribed, where was it administered, what was the payer, are there any trends in the payer. But I think the most meaningful for our groups, which include the team handling the denial, the pre-certification team, as well as those operational pharmacy leaders, is what happened, where did the process break. And so information that you can't get just from what the claim reason is coming back is what our pharmacists and our denial specialists do. They dig into where did the process break down? How do we prevent it from happening again? Is it a system error? Was it a person error? Is it just a one-off? What was the true root cause? And that's what's used in monthly operational meetings to provide back to the front line to drive and adjust front-end change.
What about staff? What positions do you have, and did you have to add more to handle the workload?
We did. So in 2014, we started with a pre-certification team that had 4 technicians, and they were really supporting oncology as well as our rheumatology infusion center. However, over the last 5 years, our infusion operations have steadily grown, both in oncology and outside of oncology, and our team has expanded to take on 6 additional infusion centers, and it is now supported by 13 team members. So we've gone from 4 to 13, and that 13-member team is 11 certified pharmacy technicians that complete the pre-certification and enroll patients into the manufacturer assistance program. 1 individual who focuses strictly on medical necessity evaluation, so payer policies, off-label use, looking at clinical compendia to make sure that things align from a medical necessity standpoint, and then 1 supervisor. So we've gone in 5 years from 4 to 13 on the pre-certification team. And then the denials program was justifying a new pharmacist as well as a denial specialist onto that team in the last 2 years. And that was done through looking at opportunity within the financial data.
Finally, do you think that there are ways that smaller organizations can model some principles from your program?
I do. I think this work requires process owners and it requires content experts. Having a variety of different people with various training touch this type of work intermittently is not necessarily going to be the most efficient or most effective. And so I'd say the takeaways based on the complexity of the work, not only because it's oncology patients and their treatments are complex, but also because of the payer landscape. It's having process owners, having those content experts. I think that the smaller institutions could take away that accessing and understanding your denial data and really understanding where processes broke down, whether it's small scale for a smaller site or large scale for an academic institution. Looking to your denial data to help drive front-end change is vitally important. I think that the other big pieces to take away for other institutions would be that there needs to be transparent communication and operational infrastructure in place. It's requiring pre-certification or saying you're going to do this work will only get so far if people don't know when it's happening or are they authorized to treat? Is it good to go? Or someone isn't occasionally saying we have to wait. We need to make sure that the pre-certification is happening. I think about the biggest things being having the operational infrastructure in place to communicate, having that transparent communication between the folks who are doing this work and the providers that patient is good to go, having those owners and content experts within this space, and then just having access to that denials data that can help drive front-end change. Those are the big things that I think doesn't matter what scale you're talking about.
We'd like to thank Dr. McBride and Dr. Francart for their perspectives today. You can find the resources mentioned in today's show, including ACCC's Oncology Pharmacy Education Network, in the show notes, or on the ACCC website at accc-cancer.org/podcast. If you like the show, please share it with your colleagues and leave us a rating and a review. We certainly appreciate it. Next time on Cancer Buzz, we'll take a look at immunotherapy from an emergency medicine point of view. What busy ED providers need to know about cancer immunotherapy, and how patients and providers can improve communication and collaboration. Until then, this is Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.